Good afternoon and welcome to Conversations on Showing Up for Kids. My name is Tim Markle. I'm director of the Southern Regional Center for Children and Youth with Special Healthcare Needs. We're out of the Waisman Center at the University of Wisconsin-Madison. We are recording this today, so please be aware of that. I am so excited that we get to talk prevalence, disparities, and lessons learned from WISADDS. And we have our experts with us today, Maureen, Durkin, and Angelica Salinas from the Wisconsin Surveillance of Autism and Other Developmental Disabilities System. WISADDS, which I thought Southern Regional Center for Children and Youth with Special Healthcare Needs was quite the acronym. You guys have quite the acronym. So we want to talk a little bit today about what prevalence means, how prevalence is determined, and if we're looking at any disparities, and basically what lessons are we learning? Because I know this project has been going on for years, Maureen and Angelica.
Yes, it's been going on since since 2000, so more than 20 years. But that's not unusual for a surveillance system because the whole point is to begin counting the number of cases in the population and then looking at trends over time. And are we getting better? Are we improving? Are we learning anything from it? And that takes quite a bit of time. So it's basic epidemiology and
the basic epidemiology, which you always have to teach me what that is every single year. So
I thought everybody knows that.
not all of us know what epidemiology is, believe it or not. But but thank you for explaining that this has been going on for a while and the purpose of it. I'm always interested in that, especially when something has been ongoing, such as the surveillance project.
Yeah, I mean, we don't, something like surveillance doesn't lead to breakthroughs in knowledge necessarily, or, new cutting edge fixes, but it's a way to at least, it's like the first step, of sort of understanding how many people are affected, who's affected, what kind of disparities do we see in differences in prevalence in the number of people are affected? Does it vary by certain groups? And then that often leads to clues about, interventions needed, treatments needed, and things like that. And then once those become available, you can use the surveillance system to also evaluate whether it's leading to improvements or not. So
it's sort of like knowing the state of what's out there, knowing what's out there, and then knowing people are trying to change whatever that is, and measuring what that change might be for good or bad, but just sort of measuring, there's something we want to change. We're doing something to try to change it. Is it working?
Yeah, and I think the issue with, certainly with autism surveillance, is that we had been at a period where it was really kind of an ignored problem. The Centers for Disease Control and Prevention has been doing monitoring of a lot of other health outcomes for decades, including other developmental disabilities and birth defects, and then a host of infectious diseases, diabetes, you name it, lots of things. But they didn't, when autism kind of came under the radar, it came into light in the 1990s, a little bit more into public attention, there was concern that the rates might be increasing. And so then CDC was called upon to, what are we going to do? We need to start monitoring autism. And I think when we look back, we can see that it was kind of an ignored problem before that. And one of the probably most important things that the prevalence numbers do is they put it on the map, so to speak. They bring it into our awareness. And the families that are affected and individuals affected aren't just on their own anymore. There's more awareness that this is affecting a lot. And we're seeing now it's affecting more than 2% of children. And that's really pretty
That's
high.
A lot of children.
Yeah.
All right, I think I've interrupted you guys enough, so I'll let you get back to the PowerPoint and work your way through.
Sure. Do you want to say anything, Angelica, about this?
About the work? Well, I was going to say a lot towards the end, but
okay.
Yeah, just thank you everybody for being here. And if you have any questions throughout it, just feel free to ask. And I see at least one familiar face on today. So it's nice to see people join us. Yeah.
Yeah, Angelica is the project coordinator for all this work for our Wisconsin site. I guess one thing I could say about this map is that the stars indicate which sites across the country are participating in surveillance of autism in 4 and 8 year olds. And I don't know, I think there's, okay. So the purple ones are doing both 2 age groups, 4 year olds and 8 year olds. And then the blue stars are actually 3 different age groups in a way. And that includes us here in Wisconsin. So we're doing like counts of the number of children at age 4, 8, or at age 8 that have an autism spectrum disorder. And then for the 16 year olds, we're actually just following up those who were reviewed when they were 8 years old for having autism and see how they're doing now on a range of indicators and their transition plans, things like that. And one of the things about this map is it's the sites that are participating. It's not a random sample of sites around the country. What CDC has done since 2002, when we joined in this network, is every 4 years they put out an RFA for sites to apply to be an ADAM site. And we have done that so every 4 years since that time, and we've continuously been funded. But it's just sort of a chance element of who gets selected for the funding. And we've been fortunate, I think, in our state that we've been involved this long. And we have like really longitudinal data on the prevalence of autism in our state. Any questions, or do you want to go, should we go to the next slide? Yeah, and then this just shows since 2000, different sites have participated in different years, but it's generally been around 11 sites across the country participating. And every 2 years we publish in this publication called the MMWR, we publish the prevalence findings. And we've been doing this since for 8-year-old children. And you can see that over time, the gray line in the middle is sort of all boys and girls combined. And you can see that almost every year it increases, and it's just been a steady increase. And then you also, when you compare the red line, which is prevalence in girls, to the blue line, prevalence of boys, you see that it's really this very pronounced difference in gender difference, where boys have a much higher prevalence of autism than girls. And this is a consistent finding in every epidemiologic study ever done on autism, finds this big difference, and it's one that we still don't really understand. So here the role of the epidemiology and just describing it is to just raise the question, what is this? And then it could lead to research to try to figure out why it is true, and that might lead to breakthroughs in understanding autism. But at this point, we just have to say we don't really know what accounts for this. Do you want to do the next slide? Yeah. And this is just another way of looking at the same data, but not by boys and girls, just overall. So every 2 years, the publications have shown, almost every year an increase. Every 2-year period, we're seeing that prevalence continue to rise, with our most recent estimate being 23 per 1,000 children, or that's also the same as 2.3% of children having autism. And then it could also, that's the same thing as saying 1 in 44. So there's a fair amount of publicity out now, that the prevalence of autism in the United States is 1 out of 44 children. When we first started doing it, it was 1 out of 150, and it's continued to increase. And then that's sort of the national picture, but then we wanted to just comment a little bit about here in Wisconsin. So we have been, for our most recent prevalence report, it included these 8 counties of southeastern Wisconsin. And what we found for Wisconsin, even though overall the prevalence was 2.3% nationally, for 8-year-olds, we were a little lower than that at about 1.9%. And then the highest site was California, which had almost 4% of children meeting criteria for autism. And then that was 8-year-old children. 4-year-old children, slightly lower prevalence in Wisconsin than 8-year-old children, but not much different really. And here we're a little bit above the national average. At we have 1.8% of 4-year-old children in our community meet criteria for autism, and it's 1.7% when we combine all of the sites.
And what's different about this age group is that this is the first surveillance year where the kind of tracking area for 4-year-old children was the same as our 8-year-old area. So it was really interesting to see the numbers come out.
And then I've just a few more things about the 4-year-olds. I mean, historically, what we have found, and we reported a lot about this in the past, is there was this idea that autism is, you know, sort of a rich kids type of developmental disability, and mostly affects white boys and things. That was kind of the public reception. And when we first started our autism reports, it was kind of confirming that. There was a big difference. The prevalence was highest in white boys and lower in children of color in general. And that led to a lot of awareness raising. And it turned out that, you know, there were disparities in screening for autism and in providing services, which then just would get reflected in our prevalence numbers. And I think that I would like to say that we could maybe take some credit for the fact that there's been greater awareness that autism affects children in all groups. And with that, there's been improvements in identification. But we were really surprised to see these findings for Wisconsin, where every year we've done this until before 2018, Hispanic children had a much lower prevalence than any other group. But now for the first time in 4-year-old children, we're seeing this much greater prevalence of autism in Hispanic children relative to other groups. And I don't know, do you want to say anything more about this?
Well, yeah, I was going to say, you know, I think with our Latino or Latinx community here in, at least Dane County, there's a lot of professionals that are out there that are doing a lot of great work in collaboration with La Movida radio station, which is a Spanish-speaking radio station. Every day around 10 a.m. I believe that's the time, there's a different topic of information that's just out there for the community. And Dr. Patricia Tellez-Giron, who she's an associate professor at the University of Wisconsin in the Family Medicine and Community Health Department. And she also co-chairs the Dane County Latino Health Council. She is just a tremendous advocate and voice for our Latino community. It's really like, if she says it, she has just created so much trust in the community that when she comes on the radio, everyone listens, everybody turns on their radio and listens to her. And I do think that, you know, the partnerships that different groups at the university are doing with La Movida and some of these other, I guess, specialists in, you know, in our community has really, I think, helped increase this prevalence for Hispanic children, and just bringing awareness to the need, and specifically to autism, but other many developmental disabilities that there are. And so she actually was able to provide this really great quote for us in our community report that we did. And I can just read it for everyone. She said, "The Latinx community is the largest minority and the fastest growing in the United States, yet many of their healthcare and social needs are not often taken into account when developing programs. Many times programs are developed with the collaboration of a community experts and not considering the needs of this community, like language and culturally appropriate materials, particularly in the area of children with special needs. we are seeing a marked increase in cases of autism in our community. Going forward, we hope that more appropriate programs could be developed to address the needs of this vibrant community. So I think that awareness and knowing that all of the services that are being provided at all of these different great organizations maybe, you know, need to focus on, are they providing appropriate services for different groups in our communities. And I know that, you know, Dr. Diaz-Giron has been a big part of this and a big voice for us.
So Angelica and Maureen, this may be a question that you guys may not be able to answer, you know, based on the subject, but I mean, are you seeing when you're looking at the prevalence and different ethnicities and races, are you seeing any like internal differences, like Hispanic children are more likely to be delayed in the social realm, whereas white children are more likely to be delayed in speech? Or is this data so aggregate that we really can't tell? We can't nuance it that much?
I think it's, there are some things we can see, maybe not as nuanced as we'd like, especially around linguistic issues and that. But we do see that Black children with autism are much more likely to have co-occurring intellectual disability, and Latinx children somewhat more than white children. And the other thing in that girls are much more likely to have comorbid, co-occurring intellectual disabilities, seizure disorders, other things. They seem to be more severely affected on average than boys who are identified with autism. So there are these differences. We haven't fully sorted out the reasons for them, but one of the risk factors for autism that we're finding quite consistent is very preterm birth and low birth weight. And African-American infants are more likely to be affected by that than other groups, and whether that's what's contributing to the higher prevalence of intellectual disability in that group, I don't know. But there are differences, maybe not very nuanced, and we don't have a full understanding of them.
So this is just kind of what's next for ADAM and WISADDS. I included some links for our latest MMWR reports and our community report on autism, so people wouldn't have to, although I don't think it's that hard. I think you can just Google ADAM and it pops right up. Yeah. But those are the links for most recent publications that we have. We do have upcoming publications on trends for our 16-year-old group that is new this surveillance year. So be on the lookout for those if you're interested. And then we are doing some work with statewide county estimates, right? We're trying to see if we can provide, looking at statewide, what do those numbers look like? And I don't know if you want to say more about that, Maureen.
Right, I mean, I think that you might wonder, why do we just the 8 counties in Wisconsin? And it turns out that the CDC funding is limited, and they will only fund you to do a certain area size. It has to be contiguous, because they don't want you to just cherry pick, you know, high risk areas or whatever. But it has to be fairly large, but there isn't enough funding to do the whole state, for example, because it's a fairly labor intensive process. But they have asked us to start exploring ways of doing this differently, where we could produce statewide estimates. And we're working on that right now. And it's going to be, I think it's going to be a game changer. I think we're going to be doing these prevalence estimation differently in the future, and that in a way that and it's partly made possible with the electronic health records and other sources of information, that we can be able to generate statewide estimates, maybe more timely too. And I think, I don't know, I mean, to date, you know, looking at Dr. Diaz-Giron's admonition to us that a lot of this work is done without engaging communities and getting their perspective and deciding what should be done. I'm hoping we can rectify it, put more effort into that part of things in the future, and use more automated ways of getting the data. It's challenging, but that's I think going to be the future. I think we're kind of some people have called for having an ATOM site in every state. Why do just certain states have it? Well, it's limited funding and limited interest in doing this work. But if we could use other methods of generating statewide, then every state in the country could have like an ATOM site and use the information to guide policies in their own communities.
Now, could you briefly explain to us how, because you said you have 4-year-olds, you have 8-year-olds, and now you have 16-year-olds. How are you determining autism?
In the different age groups?
In the different age groups?
Yeah.
And...
Oh, good question. Well, for 4-year-olds, we review records for children who had any kind of including birth to 3 programs or special education eligibility and medical records that indicate having been referred for a comprehensive developmental assessment or an autism diagnosis or screening positive. So we a team of abstractors reviews the information in these records, and it ends up resulting in a de-identified data file with no identifiers, but the information from multiple sources are linked. So if they were seen in the school, they have school information and healthcare information, it gets linked, but then the identifiers are stripped. And that's what's used to determine if they meet the DSM criteria for autism from the information in the records, or if they had a confirmed diagnosis. That's 4-year-olds. 8-year-olds is very similar, but it's not the birth to 3, it's more just the school and health data. And then for 16-year-olds, it's not quite the same. Instead, we're just taking those who were reviewed at age 8 as having a suspicion of autism. At age 16, do they have a diagnosis? Did they get one in between? If they had one, did they keep it? Is there a transition plan in their school records? There's an increasing interest in the transition, like after this huge rise in autism prevalence in children, well, what about as they age over the life course? Are we ready for serving and helping these children transition into young adults and things like that, and jobs and education, all that? So that's what the goal of the 16-year-old is, to sort of also look at comorbidities, co-occurring conditions, medication use, and independence, things like that.
Now, do you anticipate with looking at 16-year-olds that may also give us some idea about the effectiveness of early intervention or later intervention? Or are we going to see people that are no longer meeting the criteria that drop off?
That's a really good question. So far, what we've seen is there's more of an accumulation of cases that are later identified. We haven't really seen too much evidence of children losing the diagnosis. But it's interesting. And one of the things that in the intervention research, it seems to show that this co-occurring intellectual disability, the intervention is becoming less common. So in the 50 years ago or so, it was thought that most children with autism would also have co-occurring intellectual disability. But over time, as the rates of autism have increased, the proportion with intellectual disability has decreased. And the interventions for autism really focus on sort of boosting IQ, to be honest. And so I think that is something that we're seeing, is that the interventions are increasing the intellectual abilities of the kids. But whether that it's really addressing the autism symptoms is another story.
Which leads into a whole can of worms of therapy and effectiveness, which we're not going to go into today because it's a really interesting conversation going on right now in the autism community.
You have to have different guests for that.
Yes.
And I would love to listen in.
Absolutely. Is that the end of the slides? Because I don't want to dominate the questions. I'm sure other people might have questions that they may want to ask, which you can either raise your hand and I can call on you, or you can put your question in the chat and I will relay it. But is there, I don't want to cut the slideshow off short though. There we go.
Yeah,
I knew there was a picture.
Nice.
Yes.
So this is just our wonderful previous abstraction team and almost our current abstraction team. I don't think that they get enough credit for the work they do because it is extremely labor intensive to review all these and look for all of the variables that we want to collect to be able to publish these reports. So I just want to give you faces. A lot of people are like, who's doing this work? Well, these are the wonderful people that have done or are doing the work currently. So just a big thank you to them.
Mm-hmm. Fantastic. So any questions out there from anybody? Seems how we have people joining us today, which is fantastic. Again, feel free to raise your hand or put it in the chat. And I had what you had mentioned, I'm always interested in those comorbidities because of the fact that right now we have a healthcare system that doesn't seem to recognize that people can have more than one struggle at the same time. And so they keep wanting to take care of one struggle, but forget that maybe it's the other side that actually needs help. What approximately percentage do we have right now with like intellectual disabilities with autism? You said that the autism is going up, but intellectual disability seems to be going down. What percentage are we at with that?
It varies a little bit, but it's closer to like a third of children. And some sites and some age groups, it's only 20% of children with autism have co-occurring intellectual disability. And so that's like a change than where it used to be the majority of children with autism had it.
That's a really low. It just seems to me that strikes me as a sort of a low number. So I could see why this is because it's striking to me that it's that few. Mm-hmm.
Yeah. And I don't know if it's that we're identifying more autism in children who have average IQ, whereas they didn't come into attention before and now they are. And it seems that that's what's also accounting for the rise in autism prevalence. It's most of the rise is occurring in children without co-occurring intellectual disabilities.
Which, like you said, definitely is going to have an impact on the therapy that they then receive. Yeah.
Another co-occurring condition is ADHD. In the previous classifications and diagnostic systems for autism, that was excluded. If you had ADHD, you didn't have autism. But now you can have both. And so there's more and more co-occurrence of those two.
Now, I know epidemiologists don't like to get out any crystal balls or anything, but we're seeing this pretty consistent rise of autism prevalence. Do we think that's going to even off at some point? This is getting a little bit scary.
Yeah, I don't.
2% of all children is a little frightening.
Yeah, I have to say, for a long time, I thought it was going to level off at 1%. So that, I would have been trying to predict. Okay, that's my prediction. It's going to level off at 1%. We just blew past 1%, and I don't know. And then we look at the California data. If that's any kind of indicator of where we're all heading, I don't know.
Because there's not a special California classification for autism. We're using the same definitions.
Yeah. They're using the same definitions. They do have a very coordinated system. It's not the whole state. This study was done in the San Diego area. It's San Diego, right, Angelica? I think. Yes. Yeah, San Diego. Mm-hmm. And they have a very, very well-developed referral systems, support systems of supports and referrals. Might be good to visit for people from Wisconsin to go and visit, see what they do. Not that we want our rates to rise, but you know, are they calling children with autism the same as how we do it here? Are they providing more supports?
Well, and I love that. I love the idea that we need to know what the numbers are so we can figure out how to scale up interventions.
Yeah.
And how to scale up therapy and affect the education system. I mean, it's impactful. The more children with any developmental disabilities within the system, it's just going to be a lot more impactful to the system.
Yeah. Yeah, it's the most expensive form of special education.
Yeah, and balancing, there's a lot of balancing acts going on in school systems. Is their funding doesn't keep going up, and there's not an unlimited pot of money. And so they're trying to make decisions. And so knowing what the numbers are and knowing what's coming up is really important.
Yeah.
Well, thank you, Tim. I'm glad you see the value of it.
I do. I hope the CDC continues to fund you guys. I really do appreciate it. Any other questions that are out there? I don't need to hold anybody up with just my questions because, of course, I could just email Maureen and Angelica when I have questions. It's very easy for me. But any other thoughts that are out there? Okay, well, I will do my best to, I do have the PowerPoint and I'll be sending that out as a PDF to people so that if you want to look at those numbers, hopefully I should have said that at the beginning so you weren't furiously writing them down on your lunch napkins. So I will get that out to you, but I really appreciate Angelica, Maureen taking your time out to join us and explain a bit more about what prevalence is. The information on disparities and the Latinx community is new to me, and that is really, I don't know if it's encouraging or discouraging. Encouraging that I think we're doing a better job identifying, but discouraging that the numbers continue to go up.
Yeah.
So thank you again so much for being here. I don't see anything coming through in the chat. So thank you so much. I appreciate it.
Thank you, Tim. Thanks for, it's so hard during this pandemic to stay connected, and I appreciate you making this effort. Thank you.
Thank you. Have a great afternoon. Thanks, Angelica.
Yeah, bye.